Stretching, this is good as arthritis progresses. Again, stiffness is one of the symptoms. So if you stretch daily, maintain your joint movement, this will preserve your motion as much as possible. You won't get back what you've lost, and in most cases it can be progressive, but it usually stems from people not wanting to go to the limits of motion because that's where they experience the pain. And if you're not stretching that capsule out or taking it to the limits of motion, then eventually it'll contract and your motion will decrease. This occurs a lot in arthritis, where a lot of the patients that come in for surgery are not able to achieve extension, and we have to correct for that at the time of surgery. We talked about aerobic exercise, swimming, biking. When biking, you still have to be careful on hills. So if you're having to go up and down hills where you have to get up on those pedals and really push, that may be something you'll also have to find out what your knee can and can't tolerate. But definitely improves your cardiovascular fitness. And again, it gets into that weight control issue. This is something you might be able to control a little bit more on an exercise bike, but it sure is nice to be able to get out and breathe the fresh air, which we don't have right now. So indoors would be better. Avoid the weight-bearing activities. If you can walk without pain, do it. It is good to get out. Strengthening exercises, again, weight and resistance training is good. This also helps to slow the progression of arthritis as long as you're limiting the impact. It also does strengthen the bone as well. Anytime somebody has been bedridden for a period of time, or astronauts in space, they start to develop osteoporosis. The bone needs that stimulation to maintain its strength. Same thing with the muscles. And as we said earlier, the muscles crossing the joint are actually what's supporting and protecting the joints. So they do work like shock absorbers from the standpoint of allowing your knee to, you don't just take the full force of the impact on your knee, it'll allow the knee to bend and the muscles can absorb some of that. Injections, short-term treatment for a chronic problem. This is a good way of putting it. Injections can be effective for a short period of time, or they can be effective for a long period of time. Cortisone injections, they can help relieve swelling. They can also help relieve pain. Cortisone is something that has gotten kind of a bad reputation. People say, well, I don't want cortisone. I heard that's not good for you. And that can be true, but in most cases, cortisone it's helpful if it's used judiciously. It becomes harmful if it's used too long or relied upon too long and not used responsibly. I give the analogy of like players in the NFL are probably receiving cortisone injections on the plane home every Sunday so they can show up to practice on Tuesday. And if you do that long enough, eventually it will weaken the cartilage. It will also weaken the capsule and the ligaments and the collagen and the tissues around the knee. And usually by the end of their careers, their knees are pretty shot, despite the fact that they're still relatively young. But it's also not a drug to fear if it's being used responsibly. It can be very, very effective. We usually combine it with some lidocaine or numbing medication in order to give the cortisone more volume to spread throughout the knee. This immediately gives you a numbing effect, the same as if you went to the dentist, but it will also wear off in a few hours. That can be very useful, though, in terms of giving us diagnostic information in terms of how much of your pain is coming from inside the joint versus maybe from outside the joint based on the response to that injection. We will usually, they say you don't want to do more than say 3 a year. And I'm not in disagreement with this. It kind of gets to a point where it's either working or it isn't. And if you're getting short-term relief from this, then it's time to move on to something else. There's also evidence that ultimately, no matter what we do, the knee will still become painful eventually, and the knee will still continue to wear out to where surgery becomes the option, and that's usually joint replacement. And at that point, there is evidence to show that there is a relation from the standpoint of how many cortisons you had before surgery, which can increase the risk of getting an infection after your joint replacement. So for that reason, we want to limit the number of injections too. We shouldn't be getting up into, I've had patients come in asking for cortisone. They've been to 3 different doctors already, because eventually the other doctors cut them off and they've had up to 25 injections. And when one doctor wouldn't do anymore, they moved on to someone else. And for those people, then I usually won't do them again either, because it's not the way to do it, and it can lead to bigger problems. You can move on to the viscosupplement injections. These are the rooster comb shots, or the Synvisc or Orthovisc or Visco 3. These are hyaluronic acid. That's a substrate of cartilage. Cartilage is made up of a structure that looks like a bottle brush. And the wire of the bottle brush is the hyaluronic acid, and the bristles on the bottle brush are glucosamine with chondroitin sulfate side chains. We're not actually replacing this and building your cartilage back up, but it does seem to have the ability to take the cartilage that you have left and make it more durable. And it, at the same time, also reduce inflammation in the knee. The effects of this can last anywhere from not at all to perhaps 6 months to a year on average. I actually had 2 patients that came in about 2 weeks apart. I looked at the patient's chart, and they were here for a follow-up following their Orthovisc injections, and I hadn't seen them in 4 years. I asked them when their pain had come back, and I was told 2 weeks ago. That is definitely the exception of the rule. I never thought I'd see that again, and 2 weeks later, somebody came in with the exact same story. Medicare will still allow these. Most other insurance companies will no longer pay for them. They have taken the position that this only prolongs the inevitable and therefore are not cost effective. They do run about $275 for a series of 3 injections. If the patient buys the syringes, they will oftentimes pay to have them injected. So that's also an option. But again, usually this would be something I'd recommend more strongly in a younger patient, where we're trying to delay their knee replacement as long as possible, so that we can keep that knee in that artificial knee in their knee longer in the long run. Platelet-rich plasma and stem cells, this is the latest and greatest, all the rage. These can also be of benefit. The data is improving on these, but there still needs to be more. Again, some insurance companies will cover this, others don't. PRP injections can range anywhere from $800 to $1,500 an injection, and stem cells can be anywhere from $2,000 an injection on up, and they come with no guarantee. They don't really have as much of an anti-inflammatory effect. But they do seem to improve pain in cases. There's some talk that they might stimulate healing. If you can microfracture a knee, and blood will fill in from the marrow and fill that deficit and form fibrocartilage, that this can sometimes strengthen that. But again, it is still somewhat experimental. So a lot of times it's going to have to be out of pocket. Again, something maybe to use when you want to be more aggressive with a younger patient.